Hello there, my treasured and highly valued viewers and listeners. Welcome back to our Pharmacotherapy MCQ series, to part 20 to be specific. My name is Dr. Nath Arwa, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare sector workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I'd like to urge you to sit back and spare me part of your precious time as I share some tips. Welcome to part 20. So question number 1 reads, a patient presents with euvolemic hyponatremia from the Syndrome of Inappropriate antidiuretic hormone secretion, abbreviated as SIADH. So my question to you is, which of the following classes of medications can cause this syndrome, SIADH? Is it the aminoglycosides? Is it the ACE inhibitors? Is it all narcotics? Or is it the SSRIs? I'll give you 10 seconds to choose the correct options from the list. In my opinion, there are two correct answers. Narcotics and SSRIs can both lead to this SIADH syndrome. Now, SIADH is majorly caused by SSRIs, carbamazepine, barbiturates, and narcotics. And I would just like to re-emphasize the fact that euvolemic hypernatremia can be seen in patients with hypothyroidism, with SIADH, with hypotomania, those who have ingested ecstasy, or those with psychogenic polydipsia and water intoxication. It can be caused by amphotericin B as well, when used for management of fungal infections. Aminoglycosides, lithium, phenytoin can also cause the same, and ACE inhibitors rarely cause SIADH, but they do cause it. So we'll move to the next question, which reads, a patient who presented with euvolemic hyponatremia hasn't responded to water restriction. So my question to you this time round is, which of the following medications would you consider administering next to sort out this problem? Would you administer lixisenatide, or would you opt for crisaborole, or would you opt for tolvaptan, or would you settle for conivaptan? I'll give you 10 seconds to choose the correct option from the list of 4. I would opt for tolvaptan. Now, if water restriction doesn't improve euvolemic hyponatremia, arginine vasopressin receptor antagonists, to be specific, may be considered as a mode of therapy. Now, what we call SALT 1 and SALT 2 trials demonstrated that tolvaptan, specifically an oral arginine vasopressin receptor antagonist, increased the serum sodium more than placebo in patients with euvolemic and hypervolemic hypernatremia in studies that were carried out. Lixisenatide, which is a subcutaneous once daily GLP-1 receptor agonist, is indicated in the treatment of type 2 diabetes mellitus. So it would not help us much in this condition. And crisaborole is a topical phosphodiesterase 4 inhibitor, and it's indicated in the treatment of mild to moderate atopic dermatitis. So it would not sort this problem either. And conivaptan is an IV arginine vasopressin receptor antagonist, and it can be used to raise serum sodium levels in hospitalized patients with euvolemic and hypervolemic hyponatremia. Now, the major extracellular cation physiologically is sodium, while the intracellular cation is potassium, and the major extracellular anion is the chloride ion. So those three have a role to play in the regulation of the volumes of water that we are able to excrete through the urinary tract. I would end up settling for tolvaptan as opposed to the other three. Let's move to the next question, which reads, the following values are reported on a patient's lab report. Sodiums are 115 milliequivalents per liter, and the glucose is 340 milligrams per deciliter. Now, basing on those, what is the estimation of this patient's actual sodium concentration? Would it be 110 milliequivalents per liter? Would it be 120, 130, or 140? I'll give you 10 seconds to quickly compute the value. The answer is B, 120 milliequivalents per liter. You can raise the sodium 2 to 2.5 for every 100 milligrams per deciliter over the 100 mark. Now, for this patient, the figure stands at 340, the glucose levels in his serum. So that gives us 340 minus 100, which is 240 above the 100 mark. So the sodium should be raised twice in this particular case for every 100, and that gives us 2 times the 2 to 2.5, which is around 4 to 5 milliequivalents per liter. So actually the actual corrected figure will be 5 milliequivalents plus the 115 that is reported in the report, which gives you a total of 120 milliequivalents, and that is the actual corrected sodium level. Now, the correction of sodium based on glucose is to raise sodium by 1.6 for every 100 milligrams per deciliter of glucose over the 100 mark, and we do that up to the 400 milligrams per deciliter level, and from then on we raise sodium by 4 for every additional 100 milligrams per deciliter. Those are the formula we use according to many pharmacology books that are quoted out there. So I would refer you to research further if I was not clear enough. Let's move to the next question. So in our next question, an arrhythmic patient presents to your hospital with a severe hypocalcemia, and you decide to administer IV calcium replacement. You are aware of the fact that 100 to 300 milligrams of elemental calcium should be diluted in 50 to 100 ml of 5% dextrose in water. So my question to you is, which of the following would you add to the D5W? Would you opt for calcium carbonate, 1 gram, or a gram of calcium chloride, or a gram of calcium citrate, or would you settle for a gram of calcium gluconate? I'll give you 10 seconds to pick on the right option from that list of 4. This would be a gram of calcium chloride. Now, calcium chloride and calcium gluconate are the two from that list that are available for intravenous use, while calcium carbonate and calcium citrate are oral preparations. I would not dare infuse them. And we know that 1 gram of calcium chloride contains 272 grams of elemental calcium. So that should be 272 milligrams, while a gram of calcium gluconate contains 90 milligrams of elemental calcium. Now, due to the differences in their elemental calcium concentrations, calcium chloride should be administered by central line, except in cardiac arrest, since it is more caustic to the smaller vessels, and it very frequently causes thrombophlebitis. So when you look at the true contents of elemental calcium per every gram, my best bet here would be to settle for calcium chloride. It would deliver the amount we need to supplement. Let's move to the next question. A patient presents to your hospital with a tremor, increased reflexes, and disorientation. Basing on these symptoms, you suspect magnesium deficiency in this particular patient. So my question to you is, which of the conditions listed below could lead to hypomagnesemia? Would it be Addison's disease, antacid overconsumption or overuse, or would it be chronic alcohol consumption, or would it be end-stage renal disease? I'll give you 10 seconds to choose the correct answer. Chronic alcohol consumption it is. Magnesium depletion can result in tremor, in tetany, in increased reflexes, in personality changes, disorientation, psychosis, and prolonged QT interval, among many other signs and symptoms. And we know that hypomagnesemia is commonly caused by pancreatitis, severe burns, digestive system disorders, excessive diuretic use, chronic alcoholism, among many conditions. So C would be my best bet in this particular question. Let's move to the next question. Which of the following electrolytes listed below should be administered via central line only? Would it be calcium chloride, calcium gluconate, potassium salts used in supplementation, or sodium salts? I'll give you 10 seconds to pick the correct answer. So calcium chloride it is. Now this calcium chloride should be administered via central line due to high incidences of thrombophlebitis when you administer it peripherally using the smaller vessels. The exception to this rule is during the implementation of ACLS in patients who have experienced a PEA cardiac arrest. In all other circumstances, we should administer it via a central line because of the caustic nature of calcium chloride. So let's move to the next question. Which of the following lab works isn't useful in the workup of or for hyponatremia? Is it the CBC? Is it a complete metabolic profile? Is it the lipid profile? Or is it spot urine sodium? I'll give you 10 seconds to choose the correct option from that list. CBC it is, in my opinion. In a workup for hyponatremia, a basic metabolic panel or comprehensive metabolic panel and a spot urine sodium with or without chloride is helpful, along with considering a lipid profile. A CBC isn't likely to aid in the workup or diagnosis of hyponatremia. Now the CMP provides electrolytes, kidney function, liver function, and glucose, while a spot urine and the lipid profile may shed light on an etiology of hyponatremia. Pseudo-hyponatremia can be seen in hyperglycemia, multiple myeloma, or a lab draw error by the phlebotomist. A spot urine sodium with or without chloride can provide a clear picture if the kidney is losing excess sodium or not. So that explains briefly, in a nutshell, why I would be biased towards answer A. Let's move to the next question. So TOZ is a 56-year-old man diagnosed with multiple myeloma and osteolytic bone lesions. His oncologist decides to initiate a monthly zoledronic acid infusion. So my question to you is, which of the following adverse drug events would you inform and counsel Mr. TOZ about? Would it be about acute renal failure, osteonecrosis of his jaw, and hypocalcemia? Or would you warn him about an impending AFib, acute renal failure, and congestive heart failure? Or would it be osteonecrosis of the jaw, congestive heart failure, and bone pain? Or would it be congestive heart failure, osteonecrosis of the jaw, and acute renal failure? I'll give you 10 seconds to choose the correct answer from that list. Settle for acute renal failure, osteonecrosis of his jaw, and hypocalcemia. Now, patients starting or initiating zoledronic acid should be counseled on the risks of renal toxicity, osteonecrosis of the jaw, musculoskeletal pain can occur at times, and hypocalcemia. Now, congestive heart failure isn't typical in treatment involving zoledronic acid. Now we have two products, Relclast and Zometa. Zometa is approved for the treatment of hyperkalaemia of malignancy and for multiple myeloma patients and at times solid tumor patients with documented bone metastasis from solid tumors at a dose of 4 milligrams infused IV once every 3 to 4 weeks. Now the second product, Relclast, is approved for the treatment and prevention of osteoporosis and the treatment of Paget's disease at a dose of 5 grams, not 4 like in the previous case, but 5 grams infused IV once every 1 to 2 years, depending on the indication. That was just by the way to inform you that there are two products in the market, And when dispensing, you need to know which one is applicable for which condition. Let's move to the next question. It reads, which of the following can result in hypokalaemia? Is it the administration of salbutamol? Is it stable type 2 diabetes mellitus? Is it extensive second and third degree burns? Or is it the administration of losartan in cardiovascular disease? I'll give you 10 seconds to choose the correct answer. So in my opinion, answers A and C are correct. The beta agonists can cause hypokalaemia if the patient is on the lower end of normal range of serum potassium due to their ability to shift potassium into the cells as they activate what we call the sodium potassium ATPase pump. Now, diabetes mellitus is generally not associated with potassium abnormalities. However, if a patient is experiencing diabetic ketoacidosis, I'll underline that, hypokalaemia and hyperkalaemia can be seen or experienced depending on the time of presentation in the course of the DKA. Now, extensive second and third degree burns can cause loss of permeability, which leads to loss of fluids and electrolytes. Now, in that kind of scenario, you may end up with hypokalaemia. Now, the S inhibitors and the ARBs and even renin inhibitors can cause drug-induced hyperkalaemia by decreasing aldosterone activity, which blocks sodium and water reabsorption and retains potassium, leading to a not a hypokalaemia. So let's move to the next question. In which of the conditions listed below is euvolemic hyponatremia commonly witnessed? Is it in chronic kidney disease, heart failure, hypothyroidism, or SIADH? I'll give you 10 seconds to choose the correct answer or answers from that list of 4. In my opinion, choices C and D are both correct. It can be seen in patients with hypothyroidism, SIADH, hypotomania, those who have injected ecstasy, psychogenic polydipsia, and water intoxication. Now, heart failure and chronic kidney disease are common causes of hypervolemic natremia. That is due to an increase in both total body sodium and total body water. But the total body water is much greater than the total body sodium in such pathologic states. Hypovolemic hyponatremia can be seen in patients with fluid loss, such as sweating, diarrhea, vomiting, etc. Third spacing, that is bowel obstruction, burns, even diuretic use, or sodium wasting syndromes. That is just a by the way. So let's move to the next question, which reads, why is hyperkalaemia common in chronic kidney disease patients? Is it because of a decrease or decreased aldosterone activity? Or is it caused by decreased renin release? Or is it caused by impaired potassium excretion? Or is it caused by increased muscular contraction? I'll give you 10 seconds to choose the correct answer. My opinion, it's caused by impaired potassium excretion. It is common in later stages of chronic kidney disease due to impaired potassium excretion. Now, kidneys are one of the primary regulators of total body potassium, sodium, magnesium, and calcium. Now, ACE inhibitors and ARBs and the renin inhibitors, also by the way, are causes of drug-induced hyperkalaemia, and they do so by decreasing aldosterone activity, which blocks sodium and water reabsorption and retains potassium. Now, beta blockers can decrease renin release at the juxtaglomerular cells in the nephron, which directly decreases aldosterone. Succinylcholine, however, increases muscular contractions, which may compound any underlying hypokalaemia. And then digoxin decreases the sodium potassium ATPase activity, causing potassium to remain extracellularly. And this is commonly witnessed when there is an overdose of digoxin. And on the other hand, NSAIDs can be a compounding factor in causing hyperkalaemia by decreasing prostaglandin I2 mediated perfusion of the renal afferent arteriole. So that was just a by the way, but in my opinion, impaired potassium excretion would be the major cause of this challenge, this hyperkalaemia in the chronic kidney disease population. Let's move to the next question. It reads, which of the following isn't a common etiology for the development of hypocalcemia? Is it diminished intake of calcium? Is it hypothyroidism? Is it multiple myeloma or vitamin D deficiency? I'll give you 10 seconds to choose the correct answer. So, in my opinion, multiple myeloma is the correct answer. Hypocalcemia can be caused by diminished intake, hypothyroidism, and vitamin D deficiency. Multiple myeloma can cause hyper, not hypocalcemia. It does cause hyperkalaemia. So that makes it the right choice among the four. Let's move to the next slide. So the question reads, you are part of a team managing a lady who weighs 187 pounds and has acute hyponatremia. Now her labs show a serum sodium level of 116 milliequivalents per liter, and you decide to administer 3% hypertonic saline, which contains 513 milliequivalents of sodium per liter. So what rise in sodium levels would you expect with 1 liter of this infusate? Would it be 5, 10, 15, or 20 milliequivalents per liter? I'll give you a few seconds to compute the arithmetic there. So in my opinion, B is the correct answer, and I'll give you a few seconds to look at how I got to that answer. Now, in case the 10 seconds are not enough, I would advise you to pause the video or replay it at a later date and stage. So let's move to the next question, which reads, PaO is a 59-year-old male with squamous cell carcinoma of the tongue, and he presents to your clinic with symptomatic hypocalcemia. Now, his ECG reveals a shortened QT interval with a widened T wave. He had potassium level of 3.3 millimoles per liter. His serum creatinine was 1.5. He had a calcium of 12.6, and the AST and ALT are 20 and 24 units per liter respectively, and his albumin stands at 3 grams per deciliter on presentation. So my question to you is, which of the listed options would be the most appropriate first-line treatment modality for hypercalcemia of malignancy in this patient PAO? Would it be prehydration with normal saline followed by pamidronate 60 milligrams infused IV plus gallium nitrate dosed at 200 milligrams per meter square infused? Or would you hydrate with normal saline and then infuse zoledronic acid 5 milligrams and add calcitonin to that? Or would you hydrate with normal saline and infuse 4 milligrams of zoledronic acid before adding calcitonin? Or would you hydrate with normal saline and then administer gallium nitrate dosed at 200 milligrams per meter squared followed by calcitonin? I'll give you 10 seconds to choose the correct regimen. I would settle for option C. Initial therapy should consist of IV hydration using normal saline, a biphosphonate, and calcitonin. Patients with hyperkalaemia are usually dehydrated, so IV hydration helps to dilute the calcium concentration in their serum or in their blood and increases renal excretion of calcium. Remember, they have hypercalcemia. Now, biphosphonates such as zoledronic acid and pamidronate are initiated as soon as possible, since the response requires an average of 2 to 4 days, and the nadir in serum calcium may take up to as long as 4 to 7 days after treatment is initiated. Now, calcitonin is needed as the patient has a moderate hypercalcemia, but it is symptomatic as evident on the ECG. You remember what we are given on the ECG. Now, calcitonin will result in a more rapid response within an average of 12 to 24 hours. Now, I would like you to be warned that tachyphylaxis may occur and its effect is limited to the first 48 hours. Now, just as a by the way, gallium nitrate is useful in refractory hypercalcemia, but can cause nephrotoxicity, be warned, and hypophosphatemia. Yeah, that's why I would shy away from it in this particular patient's case. Now, zoledronic 5 milligrams, not 4 but 5 milligrams IV is not FDA approved for this particular patient's condition. It's for osteoporosis, remember, but for the treatment of osteoporosis, so don't use 5. I would not settle for 5. That was a trick to make you pick the wrong answer. Now, studies have shown that zoledronic acid is more potent than pamidronate. That's why I picked C and not A, with a similar toxicity profile in the treatment of hypercalcemia of malignancy. Yeah, that's why C becomes preferable to option A, B, and D. Then, just as a by the way, intranasally administered calcitonin isn't effective for the treatment of hyperkalaemia. So just remember that. Let's move to the next question. PAO is a 59-year-old male patient with the squamous cell carcinoma of the tongue who presents to your clinic with symptomatic hypocalcemia. I think we are talking of the same patient. My question to you this time round is, which of the following is the most appropriate corrected calcium level for our patient PAO? Is it 11.6, 12.8, 13.4, or 14.1? I'll give you 10 seconds to quickly compute that value. So the correct answer, in my opinion, is C. Now, corrected calcium should be calculated when the albumin is less than 3.5 grams per deciliter. About 50% of calcium is bound to albumin in the body, and in the setting of low albumin levels, corrected calcium will provide a better estimation of free calcium in a patient. Remember that. Now, corrected calcium can be computed as measured calcium plus 0.8 times 4 minus the measured albumin. So in our case, it would be 12.6 plus 0.8 times 4 minus 3, which gives us a value of 13.4. So free calcium is the physiologically active form responsible for any form of biological action. That is just a by the way. So let's move to the next question, which reads, which of the following can be observed in a patient presenting with hypokalaemia? Is it myalgia, hyperreflexia, peaking T waves, or tetany? I'll give you 4 seconds to choose the correct answer from those options. In my opinion, D is the correct answer. Fasciculations and or tetany may be observed in patients with hypokalaemia. Peaked T waves, which is the option number C on the ECG, are sometimes seen in patients with not hypokalaemia, which can cause hypokalaemia can cause U waves on an ECG, not peaked T waves. Remember that. Then hyperreflexia is the most commonly associated symptom with a lesion or a mass or compression of the upper motor neurons in the central nervous system, not in this particular state. Then myalgia can occur from a number of conditions, but never hypokalaemia. Hypokalaemia is not one of them. So the best answer in this particular case would be tetany. Let's move to the next slide. A patient comes to the clinic with complaints of nausea. His sodium is 108 milliequivalents per liter, very low indeed. What would you recommend for this particular patient's treatment? Would it be a metro, hypertonic saline, ondansetron, or water restriction? I'll give you 10 seconds to choose the correct answer. So I would settle for water restriction. Patients with sodium levels of 110 or below often present with nonspecific symptoms and respond best to water restriction, especially when they don't present with a change in mental status. Remember, they've not talked of change in mental status in this particular case. Now, phosphorylated carbonated solution like emetrol is used to manage nausea, and hypertonic saline is used for acute symptomatic hyponatremia to provide immediate improvement of symptoms, especially when patients are seizing, when they're experiencing seizures. Then ondansetron is a 5-HT3 receptor blocker used to prevent nausea and vomiting. So it would not help a patient in this particular case, just as a by the way. Let's move to the next slide, please. Patient has potassium level of 6.2 milliequivalents per liter and was verified not to be from hemolyzed sample of blood. So what ECG changes would you expect to see in this patient's case? Would it be peaking T waves? Would it be U waves? Would it be ventricular fibrillation or a wide QRS? I'll give you 10 seconds to choose the correct answer. So in my opinion, it would be peaking of T waves. Now, mild hyperkalaemia is defined as a potassium level of 5.5 to 6.5 milliequivalents per liter with ECG changes of peaked T waves. Now, severe hyperkalaemia is defined as levels above 7.5 with ECG changes of loss of P wave and wide QRS sine wave, and in some such cases also ventricular fibrillation is the most common type of arrhythmia. So that explanation makes A the correct choice. Now, U waves are typically seen with hypo, not hyperkalaemia. Then hypokalaemia is associated with the prolongation of the QT interval. I hope I made myself clear. So let's move to the next slide, please. So which of these medical conditions doesn't cause clinically relevant hyperkalaemia but can result in hypokalaemia? Is it Addison's disease, or would it be bulimia nervosa, or would it be severe burns or congestive heart failure? I'll give you 10 seconds to choose the correct answer. So in my opinion, two answers would be correct: congestive heart failure and bulimia nervosa. A hyperkalaemia can be caused by ketoacidosis, by a myocardial infarction, by severe burns, acute and chronic kidney failure. Even fasting can do so. A GI bleed could result in the same. Adrenal insufficiency and Addison's disease can all cause hyperkalaemia. But remember, we are talking of hypokalaemia in this case. So that makes D and A wrong. Now, in the context of congestive heart failure, hyperkalaemia can occur from unregulated RAS, renin angiotensin aldosterone system, where excessive aldosterone production causes the kidneys to reabsorb sodium and water while eliminating more potassium. In addition to hypokalaemia, heart failure is also sometimes associated with hyponatremia. Hypokalaemia in heart failure can be associated with hyponatremia, as I said, especially with fluid overload and hypomagnesemia. Now, the bulimia that we also chose as our correct answer is more commonly associated with hypokalaemia or potassium loss from excessive emesis. Such patients tend to vomit a lot, and in the course of the vomiting, they lose potassium from the GIT. Just as a by the way. Let's move to the next question, which reads: a patient was admitted for hyponatremia with a sodium serum level of 117 milliequivalents per liter. His case was discussed by the multidisciplinary clinical team for the possibility of beer potomania in the differential diagnosis. So my question to you is, which of the following would not be a sign or symptom of this beer potomania? Is it altered mental status, hypernatremia, gait disturbance, or average serum concentration of 1 or 8 milliequivalents per liter? I'll give you 10 seconds to choose the correct answer. So I would settle for hypernatremia. Now, beer potomania is a unique syndrome of hyponatremia which usually manifests with altered mental status, weakness, and gait disturbance, with an average serum sodium concentration of 108 milliequivalents per liter. Other abnormal results consistent with this diagnosis include hypokalaemia with a mean potassium of around 3 and a low BUN and urine sodium levels. Now, often there is a recent history of binge drinking and a history of illness. Diarrhea and vomiting are usually culprits, and this usually predisposes the patient to a rapid drop in serum levels through losses via either vomiting or diarrhea. So, my highly esteemed and cherished viewers and listeners, I highly appreciate the fact that you continually partner with me and support me in this noble venture. Now, if this video helped you in any way, I would like to urge you to remember to give it a thumbs up and to like it. And if you haven't yet done so, I would like to urge you to subscribe to my YouTube channel. I would like to promise you from the bottom of my heart that the best is yet to come. Thank you for viewing and for listening. I hope to interact with you in part 21 of this series of Pharmacotherapy MCQs. Thank you for being there for me. So, my highly cherished and treasured listeners and viewers, that brings us to the end of part 20 of our Pharmacotherapy MCQ series. I would like to let you know that I highly appreciate your partnership and your cooperation. Thank you very much for being there for me. And if this video helped you in any way, I would like to urge you to remember to give it a thumbs up, to like it. And if you've not yet done so, I would like to urge you to subscribe to my YouTube channel. And I would like to promise that the best is yet to come. I look forward to interacting with you in part 21 of this same series. So thank you for being there for me.